We shall proceed at the start of the session with the first talk being the AP State Ophthalmological Society Innovative DIY Manual Technique for Silicone Oil Removal by Dr. Ashok.
Yeah, thanks for the opportunity. Good afternoon all. I'll be talking about an innovative do-it-yourself manual technique for silicone oil removal versus a machine-based approach. It is a comparative study. I don't have any financial interest. So the aim is to study the efficacy of manual silicone oil removal by modified innovative technique as compared to the vitrectomy machine-based approach. This was a comparative interventional case series with a total of 20 eyes. Group A had 10 patients undergoing SOR by modified manual technique, and Group B had patients by vitrectomy machine-based approach. The study was conducted from Jan to March 2023. All the patients posted for silicone oil removal without the need for any adjuvant procedures were included in this case series. Coming to the vitrectomy machine-based approach, this is how with the machine-based approach we can see the silicone oil come into the extrusion syringe of the tubing, and you can see the extrusion is very slow. The silicone oil comes very slowly into the syringe, and this is all the equipment which is required for the vitrectomy machine-based approach. Whereas in our modified manual technique, what you require is just a short cut end of a infusion tubing, wherein you cut it like this. It's around 5 to 6 mm, and you connect it to the syringe. And once it is done, that this is what you require, and the video is showing the ports and the infusion bottle which is connected to the eye with the help of an infusion bottle, and it is connected via three-way, and you can see manually you just put the infusion sleeve onto the trocar of the 23 gauge trocar and just manually pull it, and you can see clearly that it comes very fastly with this, and the residual bubbles are removed with fundus is examined and partial fluid air exchange is done. So the time taken for SOR by both the techniques was noted along with any adverse events. The patients were examined on post-op day 1 week and 1 month. On follow-ups, their BCVA, IOP and status of retina was observed. Any other complications in either of the procedures were noted. So these are the results of our manual technique, and this our vitrectomy based approach. The average study of the patients were age of the patients of the study was 49 plus or minus 3.9 years. 9 were females and 11 were males. So the preoperative BCVA range from hand movements to 618. All the cases had 1500 centistokes density silicone oil. The mean time taken for SOR by our technique was around 1.92 minutes, whereas the machine-based approach it took around 5.2 minutes. The post-operative visual acuity ranged from 1/60 to 618. There was no intraoperative or post-operative complications with either of those. So coming to the discussion, earlier in a 20 gauge era, the Garodia et al. Described an active suction using 19 gauge cannulas, but whereas in 2007, Capron et al. Advocated a technique of active removal with the help of a 25 gauge micro cannulas, which were specifically designed for this. But there are other studies by Zhang et al. And Zhongling et al. Where Zhang et al. Has described a vitrectomy independent, machine independent technique of 5000 centistoke silicone oil removal with the help of a 10 ml syringe, which is lifted manually and fixed with the help of a clamp by an assistant. Zhonglin et al. Did a comparative series wherein he compared the vitrectomy and a manual based approach wherein he used a 10 ml syringe. He described that vitrectomy approach was advantageous because of the controlled negative pressure rather than a manual technique which was faster and effective, but it required caution because there was an uncontrolled pressure with the help of a manual technique. So what we came to know is the 10 ml syringe when lifted up, it to the mark of 4.5, it generates a 676 mm of Hg when the plunger is fixed with the help of a clamp. So this can result in an adverse collapse of an eyeball during SOR. So our modified technique used a 5 cc syringe, which is safer and takes away the need for an assistant to clamp the plunger end as well. So when we talk of carbon neutrality nowadays, the hardly what we are using is just a cut end of a small infusion thing and a 5 cc syringe. So there is much to reduce and nothing to reuse actually. So to conclude, our technique involves a minimal equipment. So this technique may be used to perform SOR in an ophthalmic institute where it is devoid of a vitrectomy machine setup also. So our technique is economical, safe, time efficient, and an environmentally friendly approach to SOR. Thank you.
Yeah, one question.
Yes, sir.
You know कि after SOR or during the procedure you can land up into a retinal detachment.
Yes, sir.
The rate is somewhere around 10%.
Yes, sir.
So are you comfortable doing silicone oil removal in the absence of a machine?
Sir, that's what, sir. In my inclusion criteria, that's what I mentioned. Majority of it, what we have chosen is a well-attached retina, wherein we didn't even have another thing of even adding any step to the procedure, sir. In the way that I totally agree your point that intraoperatively, at least, we've selected cases where we didn't want to have a thorough examination was done. All the brakes were attached and there was no advanced procedure, sir, even in the form of a membrane being there which required peeling.
Even after a very meticulous examination, you can land up into detachments post-operatively. So my take is if you are into a system where you don't have a vitreous machine and doing a silicone oil removal, even if you have an hypotony, you will have a bleed. So how will you manage that? So there are different situations during surgery, you cannot be 100% sure.
Yes.
Chalo. Thank you. Next presenter.
Thank you very much for that interesting presentation.